1, 2,
And
Patients here.
female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
So, picture this. You're standing at the bedside in the intensive care unit. The overhead lights are dim, but, the monitors are just glaring bright.
Yeah, throwing off that cascade of yellow and red alarms. We've all been there.
Right. And your patient's heart is failing. I mean, their blood pressure is just tanking, and the kidneys are shutting down because, well, they aren't getting enough blood.
Exactly. And you look down at your hands, and you are holding a syringe containing a medication that can, either pull this patient back from the brink of circulatory collapse, or,
if you push it incorrectly, it could trigger a lethal arrhythmia in a matter of seconds, like right in front of you.
Right. The margin for error is exactly zero. That is the daily reality of critical care pharmacology. You just don't have the luxury of second guessing.
You really don't.
You have to know the molecular machinery of the drug in your hand so intimately that you can anticipate what the patient's body is going to do before the monitor even registers a change.
And that is exactly the scenario we are putting you in today. So if you are listening to this deep dive, you are stepping into a very specific set of shoes. You are a nursing student in your toughest semester, staring down critical care pharmacology.
Yep, you've got the NCLEX looming, and you are feeling the crushing weight of information overload. We've all felt it.
Oh, absolutely. But we are here to strip away the noise. Today, we are aggressively applying the Pareto principle, the 80-20 rule, to one of the most complex, high-risk medications you will ever encounter in the ICU.
Because we have a highly detailed clinical monograph in front of us, but, reading a list of facts won't save your patient.
No, it definitely won't.
Our mission is to extract the exact 20% of information that yields 80% of your clinical reasoning, your exam performance, and most importantly, your bedside safety.
Exactly. We're going to break this down from the cellular level all the way to, what you actually tell the patient's terrified family. So, okay, let's unpack this. Let's look at the label on the vial.
Okay, let's do it.
We are dealing with Milrinone. Generally speaking, it falls into the bucket of positive inotropic agents. But the specific clinical description is that it's a parenteral positive inotrope and vasodilator with phosphodiesterase inhibitor activity.
Which is a heavy string of medical jargon, I know.
It's a mouthful. Parenteral just means we are giving it via IV, not by mouth. But positive inotrope, vasodilator, and phosphodiesterase inhibitor. How do those three things actually interact inside the human body?
Well, to understand the sheer elegance of Milrinone, we have to zoom all the way down to the cellular level.
Okay, zooming in.
Specifically, we're looking at the cardiac muscle cells and the smooth muscle cells that line the blood vessels. Inside these cells, there's a vital internal messenger called cyclic AMP, or CAM-MP for short.
CAM-PP, got it.
Right. Think of CAM-MP as the internal chemical signal that shouts at the cell to start doing its job. When CAM-P levels rise, the cell goes to work.
Okay, so CAM-P is like the foreman on the construction site yelling at everyone to pick up their tools.
That's a great way to look at it.
But if the foreman yells forever, the cell burns out, right? There has to be a mechanism to quiet that signal down.
Exactly. That cleanup mechanism is an enzyme called phosphodiesterase III, or just PDE3.
PDE3.
Yeah. Its entire physiological purpose is to sweep through the cell, break down the CAM-MP, and stop the signal. It acts as the brakes on the cellular machinery.
So PDE3 is the brakes. And Milrinone is a phosphodiesterase inhibitor. So by giving this drug, we are inhibiting the inhibitor.
We're cutting the brakes.
We are cutting the brakes.
Completely dismantling them. By blocking PDE3, Milrinone prevents the destruction of SAM-MP. So the CAM-MP just builds up and floods the inside of the cells.
Wow.
And the biological consequences of this flood are where the magic and, the danger of this drug reside.
Yeah.
Because CAM-P commands the heart muscle to do something very different than it commands the vascular smooth muscle to do.
Okay, let's trace that cascade, starting with the heart.
Right.
What happens to the myocardium when it gets absolutely flooded with CAM-P?
Well, in the cardiac muscle cells, a massive accumulation of CAM-P triggers the opening of calcium channels.
And calcium's key here.
Calcium rushes into the cell and binds to the structural proteins, specifically troponin. This allows the muscle fibers to grip each other and pull with incredible force.
Because in physiology, calcium equals contraction.
Precisely. Therefore, the heart squeezes much harder. It beats with significantly more force. That is the positive inotropic effect.
Right, so it increases myocardial contractility. But the heart is a pump, and a pump doesn't just need to squeeze, it needs to refill.
Right.
If the muscle is just locked in this forceful contraction, it can't fill with blood for the next beat.
Which brings us to the second, often overlooked cardiac effect of Milrinone. The same pathway that forces calcium into the contraction cycle also hyperactivates the mechanism that sweeps the calcium back out when the beat is over.
Oh, wait, really?
Yeah. This means the heart doesn't just squeeze harder, it also relaxes much more fully and rapidly between beats. This enhanced diastolic relaxation is a concept known as lusitropy.
Lusitropy. Okay, so the heart gets a more violent squeeze, followed by a deeper, more complete relaxation, allowing the ventricles to fill with a larger volume of blood.
Exactly.
That makes mechanical sense. But what about the blood vessels? You mentioned CMP floods the vascular smooth muscle too.
This is where the biological wiring flips, which is so cool. In the smooth muscle that wraps around our arteries and veins, a buildup of CMP does not cause a calcium influx.
Wait, it doesn't?
No, it actually drives calcium out of the cellular fluid and inhibits the proteins that cause muscle contraction.
Oh, wow.
The result is that the smooth muscle relaxes. The blood vessels widen and dilate.
Hold on. If we have a patient whose blood pressure is already dangerously low in cardiogenic shock, why on earth would we give them a drug that vasodilates and drops their vascular resistance even further?
It sounds totally backwards, right?
Yeah, aren't we just going to completely crash whatever fragile blood pressure they have left?
That is the ultimate clinical paradox of this medication, and understanding it is the absolute key to mastering ICU hemodynamics.
Okay, lay it on me.
You have to look at the failing heart like an exhausted person trying to push a broken-down car up a steep, rocky hill.
Okay, I can picture that.
The heart is failing because the workload is too high and the muscle is too weak. If we just give a drug to make the heart squeeze harder, giving the person more adrenaline to push the car, they might move it a few inches.
But they are going to burn out and collapse from the effort.
Exactly, because they're still pushing against a massive hill. The resistance is too high.
So Milrinone does two things simultaneously.
Right, yes. It gives the heart a surge of cellular strength to push harder. But by relaxing the arteries, it paves the road in front of the car. It flattens the hill.
Oh, I see.
The medical term for this is reducing the afterload. The heart has drastically less resistance to pump against. At the same time, by relaxing the veins, it reduces the preload, the volume of blood stretching the heart, before it even tries to beat.
So we are simultaneously turbocharging the engine and removing all the heavy cargo from the trunk.
That is a perfect analogy.
So even though we are dilating the vessels, which typically drops blood pressure, the heart is suddenly able to push so much more blood forward, like the cardiac output increases so dramatically that it compensates for the dilated vessels.
Exactly. The forward flow improves so much that systemic perfusion is actually restored. This dual action is so iconic and so specific that critical care providers don't just call it an inotrope or a vasodilator.
What do they call it?
The conceptual term used at the bedside is an inodilator.
Inodilator. Man, that is a massive exam pearl right there.
It really is.
The moment you see Milrinone on a nursing exam or on an ICU order sheet, your brain needs to immediately flag it. Inotrope plus vasodilator equals inodilator.
Yes, and keeping that mechanism in mind makes understanding its therapeutic uses highly intuitive. We bring out Milrinone for the short-term treatment of acute heart failure and severe low cardiac output states.
We are talking about cardiogenic shock, right? Where the heart muscle is dying or stunned and simply cannot generate forward flow.
Precisely. Another classic scenario the source highlights is low cardiac output syndrome, or LCOS, following open heart surgery.
Oh, right, LCOS. That makes sense.
It's a prime example. The patient has been on cardiopulmonary bypass. The heart has been literally stopped, handled by surgeons, and put on ice.
Just writing that down makes you realize how intense that is.
It is. When they restart it, the myocardium is stunned and bruised. It needs that inodilator support to maintain blood flow to the brain, kidneys, and liver-preserving end-organ performance until the heart muscle wakes up and recovers its natural function.
And while it's predominantly an acute, short-term ICU drip, there is a very specific population that might actually go home on this medication, right? The text mentions palliative therapy for stage D heart failure.
Yeah, that's right. Stage D represents the absolute end stage of the disease. These are patients whose hearts are completely failing, and they are refractory to all standard oral medications.
They've tried everything.
Everything. They are either on the transplant list waiting for a new heart, waiting for a mechanical pump like an LVAD, or they aren't candidates for either. They are simply trying to survive comfortably.
So they might have a central line placed and carry around a small, continuous Milrinone pump in like a fanny pack just to give their heart enough squeeze and their vessels enough relaxation to allow them to sit in a chair and breathe without drowning in their own pulmonary fluid.
Exactly. It provides the sheer mechanical support required to sustain basic human life when the native organ has given up.
That's powerful.
It really is. The text also details critical uses in the pediatric and neonatal populations, specifically for pediatric septic shock, post-resuscitation stabilization, and neonates with persistent pulmonary hypertension of the newborn, or PPHN.
Let's look at PPHN for a second, because when a baby is in the womb, their lungs aren't working, so the blood vessels in the lungs are tightly clamped down.
Right.
When they are born and take that first breath, those pulmonary vessels are supposed to snap open. But in PPHN, they stay clamped.
Right. So the right side of the baby's heart has to push against this massive wall of pressure.
And the standard therapy for that is inhaled nitric oxide, a gas that dilates the lung vessels. But what if that doesn't work?
If the newborn is unresponsive to nitric oxide, Milrinone is the elite secondary weapon. It provides that pulmonary vasodilation, dropping the resistance in the lungs, while simultaneously supporting the right ventricle squeeze to push the blood through.
Okay, so we have cardiogenic shock, post-op cardiac stunning, end-stage palliative failure, and neonatal pulmonary hypertension.
Quite a list.
But there is one use in this clinical monograph that genuinely sounds like science fiction.
I know exactly what you're going to say.
It is the treatment of cerebral vasospasm after an aneurysmal subarachnoid hemorrhage.
This is a phenomenal display of using a drug's mechanism for a highly targeted problem. When an aneurysm bursts in the brain, blood spills into the subarachnoid space.
Right.
The brain tissue is highly sensitive to the breakdown products of that blood, and the surrounding cerebral arteries react by violently spasming and clamping shut.
Which cuts off oxygen to the surrounding brain tissue, causing a massive secondary stroke.
Exactly. So to stop those strokes, neurointerventionalists can snake a tiny catheter all the way up through the groin into the neck and directly into the spasming artery in the brain.
Wow.
They then infuse Milrinone intraarterially. Because it is such a potent cellular vasodilator, it forces the smooth muscle of that specific brain artery to relax and open back up, restoring blood flow to the brain tissue.
They are essentially bathing the clenched artery in Milrinone to force it to let go. That is incredible.
It's amazing what we can do.
But looking at the broader ICU picture, there are plenty of other drugs that make the heart squeeze harder, right? I mean, epinephrine makes the heart squeeze, dopamine, dobutamine, norepinephrine.
Sure.
When the critical care provider is standing at the bedside, why are they choosing Milrinone over those classic catecholamines?
The deciding factor comes down to the chronotropic tax of those other drugs.
Chronotropic tax. Let's break that down.
So, inotropic refers to the squeeze. Chronotropic refers to the speed, the heart rate. Drugs like epinephrine or dopamine are highly chronotropic. They will make the heart squeeze harder, but they act like a whip, forcing the heart to beat wildly fast.
And if you have a patient whose heart is already dying from cardiogenic shock, the muscle is starving for oxygen.
Exactly.
If you whip a starving, exhausted horse and force it to sprint, it might run fast for a few minutes, but it's going to collapse and die.
That's a grim but accurate picture.
Yeah.
The myocardial oxygen demand skyrockets. The heart burns itself out trying to keep up with the chemical simulation. The source material explicitly defines Milrinone's clinical advantage. It has minimal chronotropic activity.
So it's the elegant solution. It gives you the powerful squeeze and it drops the resistance, but it doesn't whip the heart into a raging tachycardia.
Right. The clinical comparison rule you must lock into your brain is this. Choose Milrinone over catecholamines when your patient needs increased forward flow and decreased afterload, but their failing heart absolutely cannot afford the metabolic cost of a drastic spike in heart rate.
That distinction right there separates safe nurses from dangerous ones.
100%.
Because knowing why the drug was chosen tells you exactly what to monitor. So let's transition to the physical reality of giving this medication.
Okay, the hands-on part.
The vial is in your hand. The source specifies it should be a clear, colorless to pale yellow solution. We know it's a parenteral drug, almost exclusively administered via a continuous intravenous infusion on a highly controlled pump.
And the precision of the infusion device is non-negotiable. This is never administered to gravity. And you are constantly calculating the dose based on micrograms per kilogram per minute.
Right.
Now, while a central line is strongly preferred given the drug's vasoactive nature, if emergency IV access is completely lost, the text notes it could be pushed via the intraosseous route, drilled directly into the bone marrow.
Oh, right. Though it's not officially FDA approved for IO use, in a code situation where you have no line, the bone marrow basically acts as a non-collapsible vein. You push it in, flush it aggressively with saline, and it hits the central circulation in seconds.
Exactly. Needs must in a code. But the most heavily debated and clinically treacherous aspect of administering Milrinone involves the initial loading dose.
Oh boy. Yeah, let's talk about the loading dose.
The official adult guidelines suggest an initial IV loading dose of 50 micrograms per kilogram.
And here's where the instructions get incredibly strange, honestly. The monograph says you can give that single bolus over 10 to 60 minutes. But it also explicitly says you can divide that single loading dose into 5 equal microscopic aliquots, pushing each tiny fraction over 10 minutes, only if the blood pressure remains stable.
Right.
That sounds ridiculously tedious for an emergency scenario. Why not just program the pump to push the 50 micrograms over 2 minutes and be done with it?
If you push that bolus rapidly, you will likely cause a catastrophic hemodynamic collapse. Remember the dilator part of the inodilator. Milrinone is a profound systemic vasodilator. If you flood the central circulation with a large bolus, every blood vessel in the patient's body is going to instantly relax. The systemic vascular resistance will plummet before the heart has time to increase its forward flow.
The bottom just falls out. The blood pressure absolutely crashes.
And the resulting rapid onset hypotension can be lethal. So, dividing the dose into 5 aliquots is essentially a way of testing the waters. You give a fraction, watch the arterial line waveform. If the pressure holds, you give the next fraction. You're trying to coax the blood vessels open slowly.
But even with that cautious approach, isn't the risk of crashing the patient still incredibly high?
It is so high that modern clinical practice has largely abandoned the bolus altogether.
Oh, really?
Yeah, the source text explicitly highlights this shift. Modern heart failure guidelines frequently recommend against an initial bolus. For pediatric septic shock, the text notes that experts choose not to bolus to decrease the risk of hypotension. And for neonates with pulmonary hypertension, the directive is clear. Avoid the loading dose.
That is a critical safety intervention for a bedside nurse. So if a provider orders a Milrinone bolus for a patient whose blood pressure is already hovering on the edge, you have every right and the clinical duty to question that order.
Absolutely. You must question it. In most ICUs today, you simply hang the continuous drip and let it slowly build up to a therapeutic steady state over several hours. It protects the blood pressure while slowly introducing the inotropic support.
It is a calculated trade-off. You sacrifice the immediate onset of action to prevent the immediate onset of shock.
Exactly. Once the continuous infusion is running, the standard adult concentration recommended by ASHP is 200 micrograms per milliliter, typically diluted in normal saline or 5% dextrose.
Okay, let's talk about the danger zones. We've established that rapid hypotension is a massive immediate risk. But what are the black box level, instantly lethal adverse effects that require us to stare at the monitor?
The most terrifying complications are all ventricular arrhythmias. We are talking about ventricular tachycardia, ventricular fibrillation, and torsade de pointe.
The big ones.
The text also notes potential rapid reactions like bronchospasm and anaphylactic shock, but the electrical chaos in the heart is the primary threat.
Because VTach and VFib mean the heart has stopped pumping and is just quivering, the patient has lost a pulse. If you don't shock them with a defibrillator immediately, they're going to die.
Right.
But why does a drug designed to help the heart pump suddenly cause it to electrically self-destruct?
Well, what's fascinating here is that the short circuit is the direct result of the exact same mechanism that gives you the therapeutic benefit.
Okay, walk me through that.
We talk about how Milrinone floods the cardiac cells with CRAMP.
Right, cutting the brakes on the PDE3 cleanup crew.
Exactly. That massive excess of CAMP doesn't just force the muscle fibers to grip harder, it highly irritates the specialized pacemaker cells that control the heart's electrical rhythm.
Oh, so it messes with the wiring.
It increases the automaticity and the excitability of the myocardium. The calcium overload inside the cell triggers what we call early after depolarizations. The electrical wiring gets so stimulated that rogue cells start firing off their own electrical impulses out of turn.
So you are fixing the mechanical plumbing, the squeeze, but in doing so, you are overloading the electrical grid until sparks start flying.
That is exactly what happens. The drug that saves the hemodynamics is the exact same trigger for the electrical collapse.
Wow.
This extreme excitability is also why you see a high incidence of less lethal, but still clinically significant, arrhythmias. The text notes premature ventricular contractions, or PVCs, in 8.5% of patients, and supraventricular tachycardia, SVT, in 3.8%.
And those ectopic beats are the warning signs, right? Like,
Wow.
if you see PVCs starting to march across the monitor, you know the myocardium is getting irritable.
You have to pay attention to that.
Aside from the cardiovascular system, what other organ systems are taking a hit from this drug?
The hematologic system requires intense vigilance. There is a delayed onset risk of thrombocytopenia, a severe drop in blood platelets. The text states this can occur in up to 58% of patients.
Wait, over half the patients on this drug might see their platelets tank?
Yes.
Platelets form clots. If they drop, the patient is at a massive risk for spontaneous bleeding. In an ICU where patients often have central lines, arterial lines, and surgical incisions, a bleeding cascade is an absolute nightmare.
It requires daily monitoring. You also have to watch for hypokalemia, as potassium shifts can occur, and early onset headaches, which happen in about 2.9% of people.
The headache makes total sense based on the mechanism, right? Vasodilation in the cerebral arteries increases blood flow to the head, which physically stretches the meninges and causes a throbbing headache.
Spot on.
Okay, so we have lethal arrhythmias, profound hypotension, and massive platelet drops. This brings us to a huge pharmacology pearl regarding contraindications and organ function. Who should absolutely not get this drug or need severe dose modifications?
The most critical physiologic hurdle for Milrinone clearance involves the kidneys. The pharmacokinetics here dictate survival.
The kidneys.
Milrinone is almost exclusively eliminated from the body via the urine. A staggering 83% of the drug is excreted as the unchanged raw parent drug via active secretion in the renal tubules.
83%. The liver isn't breaking this down. The kidneys are doing all the heavy lifting, actively grabbing the drug from the blood and dumping it into the urine.
Exactly. The normal mean renal clearance is about 0.3 liters per minute. In a standard patient with congestive heart failure, the half-life, the time it takes for half the drug to be cleared is roughly 2.4 hours. But consider what happens mechanically if the nephrons in the kidneys begin to die.
If the kidneys fail, the exit door is locked and bolted shut. The drug cannot leave the body.
Exactly. The drug continues to infuse from the IV pump, but it has nowhere to go. It rapidly accumulates in the bloodstream. The half-life extends from 2.4 hours to potentially days.
Oh, man.
And as that drug level climbs into the toxic range, the CMP levels inside the cardiac cells reach catastrophic levels.
Triggering the lethal VTACH and VFib we just talked about.
Yes.
This is an incredibly dangerous trap because of the reality of ICU patients. Cardiorenal syndrome is ubiquitous. The heart fails, which means it can't push enough blood to the kidneys. Because the kidneys are starved of oxygenated blood, they start to suffer acute tubular necrosis. The kidneys fail because the heart is failing.
It is a lethal feedback loop. You initiate Milrinone to save the failing heart, but because the kidneys are already dead from the lack of blood flow, they cannot clear the very drug you are using to save the patient. The toxic accumulation destroys the heart electrically.
How does the critical care provider navigate that tightrope?
By meticulously tracking the creatinine clearance, or CRCL, which is a mathematical estimate of how well the kidneys are filtering, the clinical monograph provides a strict mathematical cutoff. If the CRCL is greater than 50 milliliters per minute, the kidneys are functioning well enough that no dosage adjustment is needed.
50 is the magic number. What happens when it drops below 50?
The moment the CRCL hits 50 or below, you must begin stepping the continuous infusion dose down to prevent toxic buildup. A standard infusion might run at 0.43 micrograms per kilogram per minute. But if the patient enters severe renal failure with a CRCL below 5, the infusion must be slashed by more than half, down to 0.2.
And what about the liver? If they have severe cirrhosis or hepatic impairment, do we adjust the dose?
The text is definitive on this. No dosage adjustments are required for hepatic impairment. The clearance of Milrinone is almost entirely a renal story.
That is a massive distinction for exams. Kidneys matter, liver doesn't. So let's translate all of this pathophysiology into actual bedside nursing interventions. We know the mechanisms, we know the dangers. What must the nurse actually do to keep the patient safe?
The absolute priority intervention is non-negotiable continuous cardiac monitoring.
No exceptions.
None. The source explicitly mandates. Observe the patient closely with appropriate electrocardiographic equipment. Immediate treatment for cardiac events, including life-threatening ventricular arrhythmias, must be available.
So you never, ever start a Milrinone drip on a standard medical surgical floor where the patient is unmonitored. They must be in an ICU, step-down, or telemetry unit, and you must know exactly where the crash cart and the defibrillator are before you press start on the IV pump.
That's right. The second mandatory intervention is continuous blood pressure monitoring. Given the high risk of rapid hypotension, you ideally want an arterial line for beat-to-beat pressure reading.
And if an ART line isn't available,
The non-invasive blood pressure cuff must be set to cycle extremely frequently during initiation.
and as a nurse, you have the autonomy to hold the medication. Like, if the provider ordered a loading dose, but the patient's mean arterial pressure is hovering in the 50s, you hold the bolus and you page the doctor. You don't blindly follow the order and crash the patient.
Exactly. And if you are administering it intra-arterially for that specialized cerebral vasospasm protocol, the guardrails are even stricter. You must stop the upward titration of the drug immediately if the heart rate climbs over 100 beats per minute, or if the blood pressure drops by more than 20% from baseline.
Good to know. Now, what labs are we obsessively checking at 4 a.m. before morning rounds?
You need a daily basic metabolic panel to calculate that creatinine clearance. You must monitor the potassium closely.
Right, because of the arrhythmias.
We know Milrinone causes arrhythmias. Hypokalemia, low potassium, also causes arrhythmias. If you combine a low potassium level with a Milrinone drip, you are practically begging the heart to go into VTACH. You must proactively replace the potassium.
Got it.
And finally, you must monitor the complete blood count, specifically targeting the platelets, watching for that 58% risk of thrombocytopenia.
ECG, blood pressure, creatinine, potassium, platelets. That is the safety checklist. But there is one more critical safety check, and it involves IV compatibility. We know we can never mix Milrinone with blood products, but there is another drug interaction mentioned in this text that is a classic, notorious trap that will absolutely show up on the NCLEX and in clinical practice.
Oh yes, this is a scenario that requires a giant flashing warning sign in your mind. The furosemide trap.
Furosemide, brand name, Lasix. It's the most common loop diuretic we push in heart failure patients to make them pee out the excess fluid filling their lungs.
Right. And the clinical monograph is stark and uncompromising about this. Furosemide is incompatible with Milrinone. Precipitation may occur if given together in the same line.
Let's explain the physical reality of precipitation for a student who might not have seen an IV incompatibility in person. I like to use the analogy of a glass of milk.
Well, that's a good one.
If you squeeze a fresh lemon into a glass of milk, the acid hits the proteins and the milk instantly curdles. It turns into like chunky, solid white blocks.
That is a perfect visualization of the chemical reaction that occurs inside the IV tubing. Milrinone is an acid-base salt formulation. Furosemide has a highly alkaline pH.
So they don't mix.
When those two fluids make contact inside the tiny plastic tubing of your IV, the pH shift causes the Milrinone to instantly crystallize out of the solution.
Wow. So you have a patient on a continuous Milrinone drip. They are fluid overloaded. The doctor orders 40 milligrams of furosemide 4D push. If you take that furosemide syringe, hook it into the same IV line that the Milrinone is running through, and push it, you instantly create microscopic solid rocks inside the tubing.
It's terrifying. Those newly formed crystals are then flushed directly into the patient's central venous circulation. They travel straight into the right side of the heart and get pumped directly into the delicate capillary beds of the lungs.
Oh my God.
You have just caused a massive iatrogenic pulmonary microembolism. It is a catastrophic, potentially fatal nursing error.
The physical blockage of the lungs, how do we prevent it in a patient who desperately needs both drugs?
Separation is the only defense. In an ideal ICU setting, the patient has a multi-lumen central venous catheter. That's a single tube entering the neck that has 3 completely separate tubes inside of it that don't mix until they hit the massive blood volume of the superior vena cava.
Okay, so you just keep them apart.
Right. You dedicate one specific lumen exclusively to the Milrinone. You label it, and you never inject anything else into it.
And if they only have a single peripheral IV and you absolutely must give the furosemide,
You must pause the Milrinone pump. You must aggressively flush the line with at least 10 milliliters of normal saline to clear every molecule of milrinone out of the plastic.
Flush it clear.
Then you push the furosemide. Then you aggressively flush with another 10 milliliters of saline to clear the furosemide. Only then can you safely restart the milrinone drip.
Dedicate a line. Flush like your patient's life depends on it, because it does. Never mix with furosemide. Never mix with blood. Okay, assuming we've navigated the dosing, the kidneys, and the incompatibilities, we need to talk about the patient experience. For an ICU drip, the patient is often sedated, so we are frequently educating the terrified family standing at the foot of the bed. What do we tell them?
You avoid the cellular biology and focus on the mechanics. You explain that their loved one's heart is exhausted, like an engine trying to push against a blocked pipe.
Okay.
You tell them this medication gives the heart muscle the strength to pump more efficiently while simultaneously relaxing the pipes, the blood vessels, to take the workload off the heart.
The inodilator concept just translated into plain English? Now, if the patient is awake, perhaps on a palliative continuous infusion or stepping down from the ICU, what dangerous symptoms must they report to the nurse?
They need to understand that the drug can affect the heart's electrical rhythm. You teach them to hit the call bell immediately if they feel a sudden fluttering in their chest, palpitations, or sharp chest pain, as that could be the herald of a ventricular arrhythmia.
Makes sense.
They should also report any new throbbing headache, which we know is a common side effect of the blood vessels dilating in the brain.
Finally, how do we prove the drug is actually working? I mean, we don't give this just to make the numbers on the monitor look pretty. What is the physiological evidence that the low cardiac output state is resolving?
The clinical monograph directs us to look for the maintenance of systemic perfusion and the preservation of end organ performance. We measure this through a constellation of bedside data points.
Let's walk through that flow sheet. What does end organ perfusion actually look like?
Hemodynamically, you are looking for the mean arterial pressure, the MAP, to stabilize in a healthy range, typically greater than 65 millimeters of mercury, indicating the heart is pushing enough pressure through the newly dilated vessels.
And in looking at the organs themselves.
You look at the Foley catheter. The kidneys are highly sensitive to blood flow. If the heart starts pumping effectively, the kidneys wake up, and you will see a rapid increase in hourly urine output.
That's a great sign.
You also look at the patient's neurologic status. If the brain is perfusing, the confusion and lethargy of cardiogenic shock begin to clear.
You literally touch the patient too, right? I mean, a patient in shock has clamped down their peripheral vessels to save their organs. Their skin is ice cold, pale, and mottled with purple patches.
Exactly. And when milrinone restores cardiac output and dilates the vessels, their toes and fingers become warm, pink, and well perfused.
The ultimate evaluation of effectiveness is the resolution of the acute crisis, buying the patient time for their stunned heart to recover post-surgery, or keeping them alive long enough to reach the operating room for a mechanical assist device or a heart transplant.
That's the end goal.
We have covered an immense amount of pharmacological territory today, from cyclic AMP and cellular breaks to cardiorenal syndrome and furosemide crystals.
It's a lot to take in.
So let's distill this entire deep dive into the absolute essentials. If our listener is walking into their critical care clinical rotation tomorrow or sitting down for the NCLEX, what is the 80-20 rapid-fire survival guide for milrinone?
Okay, lock these 4 principles in. Number 1, milrinone requires continuous, non-negotiable ECG monitoring. The massive intracellular buildup of KMP highly irritates the pacemaker cells, creating a life-threatening risk for ventricular tachycardia and ventricular fibrillation.
Respect the electrical chaos.
Number 2, anticipate hypotension. Because it is a potent inodilator, the vasodilation can crash the systemic resistance. Be highly suspicious of any orders for a rapid loading dose and advocate for continuous infusion to protect the blood pressure.
Don't drop the floor out from under the patient.
Number 3, track the kidneys obsessively. Milrinone is 83% renally cleared. If the creatinine clearance drops below 50, the exit door is closing, and the infusion dose must be heavily reduced to prevent toxic accumulation and subsequent arrhythmias.
Cardiorenal failure is a lethal trap.
And number 4, the classic incompatibility trap. Never mix milrinone with furosemide in the same IV line. The pH difference will instantly precipitate the drugs into solid crystals, causing a pulmonary embolism. Dedicate a separate line or flush aggressively.
The milk and lemon juice reaction. Separate lines, always. That is an incredibly powerful summary. We took a dense, terrifying clinical monograph and broke it down into the exact clinical reasoning you need to keep your patient alive at the bedside.
That is the ultimate goal.
Yeah.
Rote memorization of a textbook won't save a crashing patient. But understanding the why, understanding the cellular mechanics and how they translate to the bedside monitors, that is what transforms a novice into an expert clinician.
Thank you so much for guiding us through this intense critical care pharmacology masterclass. I know anyone listening feels significantly more equipped to face the chaos of the ICU. But before we sign off, the physiology we explored today leaves us with a truly fascinating, broader question about the future of medicine.
It really does. We spent this entire time talking about how milrinone forces the heart to contract, not by shouting at a receptor on the outside of the cell like epinephrine does, but by sneaking inside the cell, blocking the internal cleanup enzyme PDE3, and simply altering how the cell processes its own internal messengers.
By cutting the brakes on the natural internal machinery instead of just pushing external buttons.
Which forces you to wonder, as we look at other chronic devastating diseases where organs begin to fail, how many other cellular processes could we potentially rescue in the future?
It's a crazy thought.
What if the key to curing other failing organs isn't creating stronger external drugs, but simply finding the specific internal enzymes that act as the brakes and temporarily cutting them?
It changes the entire paradigm of how we view pharmacology. We aren't just stimulating the body, we are redesigning its internal cleanup mechanisms to force it to work harder. Something to deeply consider as you continue your clinical practice. Keep connecting the dots, keep questioning the why behind the what, and we will see you on the next deep dive.